right, so here we are with finally the blood pressure Pharm lecture. This is a part of the Pharm, so it's focusing more on antihypertensive drugs. A lot of the information that you got from the sort of med-surg lecture regarding high blood pressure will be relevant to this, although this is going to focus a little bit more on mechanisms and in a few key examples that we really need to know, some side effects that we want to be aware of with medications, risks, things that we need to educate our patients on, and to determine whether or not we know what medications are given for what type of blood pressure problem. So we're looking mostly at the drugs, and at the end we'll do a little bit of a review of some more nutritional approaches and lifestyle as well, but that's going to be, I'll go through that a little quicker than the drugs, for that's the purpose of this lecture, is to focus on the pharmacology that you'll be working with in acute and critical care setting for those of you who end up going into ICU or perhaps even ER. So what do you guys think the number of people currently that have hypertension in our nation, United States, estimated to be? Would you think there's about 10 million, 25, 50, or 70 million people? And as of now, it's actually higher, but 70 million was already a few years ago, so it's probably even higher than that. So yeah, so there's quite a few people who have high blood pressure in our nation, and it is a major problem. It's an underlying factor that leads to a lot of the myocardial infarction, heart attack, heart failure, stroke, highly related with diabetes, and also kidney failure as well. So it's something that we need to understand, and we need to know the mechanisms for which and how the drugs work that we're going to be giving a lot of the patients that we see in the hospital. Our textbook and many PowerPoints like us to say that hypertension is a disease. From an NCLEX perspective and from the textbook perspective, yeah, you can assume that it's a disease, but truly we know that hypertension is not a disease. It's an abnormal manifestation, or it's a manifestation of an abnormal vascular system. So your blood vessels at the cellular level are not working properly due to what we know, as you can see in the bottom blue, inflammation, oxidative stress, and an autoimmune dysfunction of the arterial system. And because of these underlying problems that ultimately affect the vascular system, the arteries, we end up having high blood pressure or hypertension as a manifestation of these underlying conditions. We call it a disease because it has a very specific ICD code, and doctors, once they find out that if you're unable to manage it properly with lifestyle, they'll probably want to give a prescription, and for that purpose, it is considered a disease so that we can give a pharmaceutical for the so-called disease. But we know that the underlying reasons are what lead to it, so it's more of a manifestation than it is an actual disease. And really, you want to think about it as both the arteries having functional and structural abnormalities. So if the structure of the arteries is not working, that's the cellular level, the endothelium tissue, the oxidative stress, the reactive oxidative species, all of that ultimately end up affecting the structure of the vessel, and that will lead to the inability of the vessel to carry out its function, which is to remain somewhat flexible and to allow the heart to be able to pump the blood to the rest of the body, to perfuse it with oxygen and nutrients up to the brain, down to the toes, to make sure that that perfusion is happening properly. So it generally starts more at a structural level, but ultimately it is a functional. So we always must start by asking, well, what is it that's coming into the artery or the arterial system? What are the insults that are coming into the artery that are leading to this problem? And really, again, there's mainly three responses that are insulting the arterial system. That's the inflammation, chronic inflammatory response, oxidative stress, and autoimmune dysfunction to the arterial system. Some of those incoming insults can be chemical abnormalities, which can be pharmaceutical. The pharmaceuticals can lead to problems that can lead to hypertension, especially if they're depleting nutrients in the body. Toxins, whether it's from the environment, whether it's from pesticides, toxins that we inhale when we work in specific or circumstances that may lead to a buildup of toxins in the blood. Clearly, hypertension is very related to toxin buildup in the body, pesticides, metals as well. And so there's a pretty strong research out there indicating that things like chelation therapy is very positive for lowering the blood pressure. That's not your average primary doctor that is going to be looking into that, but it is up and coming, and it should be in our radar as something that is important. Blood sugars, obviously, for the viscosity of the blood, are going to increase resistance that the blood in the heart, I should be saying, has to work against. So it makes the heart work harder, because if you have thicker blood, you can imagine how the heart has to struggle to get that perfusion to the rest of the body. Lipids are cholesterol, especially small dense lipids. The HDL are the transport ones. We want to have those in a higher number when the others are more at risk. And remember, again, when we think lipids, what we should be thinking about is, again, at that vascular level, at the endothelial, at the cellular level, plaque buildup is ultimately what starts to happen, and ultimately that leads to risks for clots and whatnot. So really, lipids is ultimately, again, thinking at that cellular level, what's the damage that's happening to the arterial wall. Other biochemical abnormalities, microbial pathogenic abnormalities, chlamydia, H. pylori are issues that can lead to not only a heart problem, but even affect blood pressure. And so treating the underlying condition, whether it's a toxin buildup, your diabetes, pesticides due to not washing our fruits well or working in the farm, or other chemical abnormalities, including pharmaceuticals. So pharmaceuticals have to be thought of as really important for acute and critical care, but really for patients that are in a chronic care setting, we want to think about lifestyle approach. We must. When it comes to pharmacological treatments for blood pressure, again, as we went into a little bit more detail in the hypertension and the cardiovascular lecture that we had already, you want to understand that blood pressure is a combination of the heart's ability to put out the blood, the cardiac output, and the systematic vascular resistance that the heart is pumping up against. And so when we think about treatment, keep that in mind, and we'll go over that shortly in a second. Essential to understand when it comes to treating hypertension. What is the goal of therapy? What are we trying to get at? Well, with patients that are above 60, we want to try to keep their systolic above 150. And remember, with elderly people, we want to watch out with giving them, or with too aggressive a treatment, because that can put them into hypotension, which causes a lot of other problems, orthostatic hypotension, dizziness, risk for falls, especially in the hospital. So we do have to watch out. So try to keep that systolic below 150, that diastolic below 90. And we're going to try to treat to keep the goal at less than those thresholds. In patients that are younger than 60, then the goal should be 140 or over 90 or below as well. And again, lifestyle should ideally be the first line treatment. You will see in this lecture that we use diuretic, especially the thiazide diuretic, the most commonly used one, is considered the first line therapy. But excuse my French, but that's a bunch of baloney. The real first line of treatment for antihypertension is always going to be lifestyle changes in diet, changes in exercise, changes in exposure to stress, exposure to toxins in the environment we work in, so on and so forth. And then obviously when you're having a hypertensive crisis, forget the diet, then we really need to give something even more like a direct central acting agent to save the patient's life. So we really have to, again, keep in mind where the patient is at and what's going on in their day-to-day life. So really, bottom line with treating hypertension, bottom line with treating high blood pressure, there's really generally two ways to do it, right? Generally speaking, keep this in mind. One is if we can somehow drop the vascular system, right? Drop the vascular resistance. And we can do this by diuretics, for example, which help the patient pee all of the urine out. Pee the urine out, drops the fluid, and by dropping the fluid, you now have a lower blood pressure, which is the exact contrary to what happens when a patient has low blood pressure. What do we normally want to give? We want to contact the doctor and make sure that we give them some boluses. If they're having heart failure, we'll do smaller boluses of 250, maybe 500 if they're still not increasing their blood pressure. For the person who doesn't have fluid overload or heart failure problems, we'll probably just give them 1 or 2 liters of normal saline as a bolus to try to keep their vascular system up. So you can drop the fluids by making them pee it out, or you could, which helps lower the blood pressure, or if you need to withhold and keep their blood pressure up from falling too much, then we would want to give the fluid. So that's one way of looking at it. And then the other one is to try to increase cardiac output through heart rate, contractility, and so forth. So it's really important to keep those two approaches in mind, because you'll see that targeting the cardiac output, we're going to be giving drugs like beta blockers, which works in the heart rate, or we're going to be giving ACE inhibitors, right, which works in the more in the RAS or the angiotensin system, which is produced in the kidneys, one of the enzymes, and that's what we're trying to inhibit. Bottom line, it's treating cardiac output, and it's working differently, but still it's working on that cardiac output part of the equation. On the systemic vascular resistance part of the equation, you're really looking at either central nervous. So the alpha 2s, you have to watch out because they're stronger, more potent, because they're centrally acting adrenergics. And we won't go much into the adrenergics, except I will give a few examples that I want you to know. Most other medications are going to be peripherally acting adrenergic, and we'll go into a couple that I want you to know there as well. The receptors, we'll talk about that when we get up to that slide, but hormones, prostaglandin inhibitors, like the ACE inhibitors, it can work with constriction and dilation, as opposed to dropping volume, which is if you hold on to the salt, that's the other equation. The cardiac output is holding on to the salt, salt holds on to water, or if you decrease the salt, salt releases water. That's more the cardiac output. In this systemic vascular resistance part of the equation of what the blood pressure is, hormones work really more with vasodilation and vasoconstriction. But you have to remember that the blood vessels are already being affected by the underlying condition. So there are certain conditions we're going to want to keep in mind regarding these when we get there. I'll be specific to make sure that you know what I want you to know. There are 4 stages of blood pressure. You should know this. There's a chart in your book. There's a chart that we had in the hypertension lecture that we gave. Remember, know what the differences are, right, between 140 over 90, so on and so forth. So make sure you review this chart. This is a chart that a slide that I created, really with tremendous amount of information just packed into one. So remember, even though there's only 2 ways that we're going to be treating blood pressure through the cardiac output or the SVR, that equation, there's quite a few categories of drugs that you'll be giving in the hospital. And so the categories that you'll see are pretty often are an ACE inhibitor, the one on the top, and those tend to end in pril. But be careful, because calcium channel blocker ends in a mil, so you don't want to confuse that one with lisinopril, for example. The ARBs, right, or the angiotensin 2 blockers, for the most part, all end in sartans, losartan. There's beta blockers, and we want to be a little bit careful with this one, because there's non-selective and selective. Non-selective really means with beta blockers, as we'll cover in one of the charts later on. There's the ones and the twos. And we want to try to, and the non-selective are going to be blocking both, whereas the beta blocker, the pure beta blocker, is really going to be targeting like the atenolol or metoprolol. Those are pure beta blockers. Once they start blocking the alpha, that plays a little bit of a different role, and we'll talk about that in a second. Calcium channel blockers like nifedipine, cardizem, verapamil, diuretics, and dilators. So a lot of the slides that we're going to be talking about after this one really are going to be covering what this slide is showing you. So when you look at ACE inhibitors, there's a few things that we need to really be careful and monitor. One is a cough, and it'll be a dry cough, and generally the dry cough, so we have to educate our patient on that dry cough. And once that, if they do contact their primary doctor and are removed from that medication, the dry cough should go away if indeed the ACE inhibitor was what was causing it. And that's seen often. Angioedema is something we would not want to see. We tell the patient that if that happens, stop automatically, immediately, and contact the provider. Obviously, if they're having respiratory problems, call 911, because angioedema and swelling in the throat, the mouth, puts them at risk for breathing problems, which we don't want them to be at risk for. Also, with ACE inhibitors, got to watch out with electrolyte. Two things is it will drop the sodium, and we know that when it lowers the sodium is going to go out with the urine, water is going to follow. So again, this is working on that mechanism of dropping the fluids by dropping the sodium in a sense. And a key one that you're going to see on at least 3 or 4 slides more is ACE inhibitor can put you at risk for high potassium. So things you have to watch out for. We'll cover that in a few other slides that cover potassium related to ACE inhibitors. The ARBs, like losartan, work by blocking vasoconstriction. And if blocking vasoconstriction really means they're trying to, they're not necessarily helping dilate, but they're not letting the body vasoconstrict, which in a sense is vasodilation. And it works with the secretion of aldosterone as well. The beta blockers, we have to watch out with them because they work on your blood pressure, but they work on your heart rate. So you want to watch out with bradycardia. Usually anything below 60 is a big no-no with a lot of the beta blockers. And the asthma and the COPD aspect of it is more with the non-selective beta blockers, like carvedilol or propranolol. And those are the B1s and the B2s because what they lead to is bronchoconstriction. And if anybody has a reactive airway disease like COPD or asthma, don't give them one of those non-selective beta blockers, okay? Or beta blockers in general. Just think asthma, COPD, watch out with beta blockers. And then also with diabetics, it's also a little bit of a risk for them as well. We have to be monitoring their sugars on a regular basis. So make sure you remember that. Calcium channel blockers work by relaxing the smooth muscle and by binding calcium to the receptors. So they prevent contraction. Similar to the ARBs, by preventing contraction, it's sort of a dilation, so it's helping the heart not have to work too hard and beat too fast or have an enlarged heart to work against it's a compensatory mechanism. And then diuretics, you have to understand there's 2 types. There's potassium sparing and potassium wasting. And it's a big difference between them because if it's a potassium wasting, like furosemide or hydrochlorothiazide, you wouldn't want to give if they already have a low potassium. You'd want to make sure that you give them potassium first before they get it, or you notify the doctor, or you tell them at home, make sure that they're communicating with their primary doctor to get that potassium as well. If it's a potassium sparing, it means it won't get rid of that potassium, like spironolactone. Then you want to tell them, hey, if you're taking a diuretic that is a potassium sparing, then just avoid potassium. Watch out with potassium, or watch out with green leafy vegetables, bananas, fruits, and also salt substitutes. That's a big one that NCLEX likes to look at. So we want to keep that in mind. And obviously, anytime you give something for a reason, when you give insulin, what do we worry about? We're giving insulin because their sugars are high, but you always want to watch out and think the opposite. If you give insulin because their sugars are high, what could it cause? Well, low blood sugars. Well, if you give a antihypertensive to a patient, what could it cause? Low blood pressure. Well, when you give somebody a drug that depletes them of fluid, what could it cause? What do we always need to keep in mind? They're going to be dry. Their vascular system is going to drop a little bit, which is helping their blood pressure. But then we need to tell them to, maybe if there's no contraindications, to try to keep hydrated as well. But then again, how is that affecting the blood pressure? Interesting question to keep in mind. Dilators are a little bit more potent antihypertensive, nitroglycerin, whether it's a patch, whether it's a gel or a cream that we put on the chest, or whether it's sublingual. Things to watch out with this one. You do not want to give with medications like Viagra because those are working on the same pathway and you'd be doubling up. I forget there was a joke about a nurse who was working the ED and she saw the husband of a coworker, another nurse who happened to not be on the shift that day, come in, and he was having symptoms of myocardial infarction. And so, against HIPAA violation, she calls her best friend up from the ER. She said, "Hey, do you know your husband's here in the hospital? He's here with symptoms for a myocardial infarction, having a heart attack, and he claims that he had just taken a Viagra." And the wife was like, "Viagra? He wasn't with me, so I wonder what was going on." And then the wife of this man says, "Make sure you give him the sildenafil. Make sure you give him that sildenafil, or give him some nitroglycerin on top of it. Just make sure you give him, because obviously the joke is kill that jerk, right?" What we need to know is that we don't want to be giving dilators with any of the erectile dysfunction drugs because it could kill the patient. Don't do that. This is a chart that we went over briefly in the previous lecture that we had. It's really good if you want to organize and you're a visual person because it shows you from the brain down to the arteries, down to the heart and the kidneys, and what aspect is being blocked. So diuretics obviously work directly onto the kidneys. By decreasing sodium reabsorption, meaning by getting rid of the sodium, and water, as we know, is going to follow the sodium, and that ends up decreasing constriction, and that helps the blood pressure a little bit. Calcium channel blockers work more on the arterial walls, like the direct arterial and the alpha and the beta. They all work directly on the arterial system, and so it's important to look at this if it helps you organize in your mind. The two key factors to keep in mind are is the overall autonomic nervous system, which has the parasympathetic and the sympathetic. We all know sympathetic is a fight or flight, and we also know that the parasympathetic is the opposite. And the parasympathetic, it works with stimulating the smooth muscle, cardiac muscle, work the glands. Sympathetic is going to stimulate that heart, that blood vessel, skeletal muscle, vasoconstrict, epinephrine, norepi, get the body to go and move forward, right? So this comes into play more with the alpha-1 receptors and the alpha-2 receptors. The alpha-1, basically, when you hear alpha-1, think fight or flight. Alpha-1, think fight or flight. So think sympathetic. Alpha-1, sympathetic. And what does that mean? If you block so blocking alpha-1 is going to have the same effect as the beta agonists will, right? When you think of A2, right, you want to think about more of blocking the sympathetic. So the opposite. So if you stimulate A2, it ends up blocking the sympathetic response, which would be the same thing as blocking epinephrine or norepinephrine. So A and 1 are a little bit different in this sense, and we'll go over that very briefly. And this is what I was just talking. This sort of goes over the sympathetic nervous systems has the alpha and the beta receptors there at the end. That's the adrenergic, and then the muscarinic is up at the top. We won't go into this detail. I'll tell you what I expect you to know in a little bit more in detail. This is a repeat. I want you to go over this on your own time and read, because it tells you, if you can really understand that there's two ways to treat hypertension: decrease the volume that's circulating in the blood or reduce the resistance that the heart's working against. So this will give you a really good, clear picture of which drugs do what. Diuretics, they promote sodium and water excretion, decrease the plasma volume, but also the extracellular fluid volume as well. And the adrenergic inhibiting agents diminish the sympathetic nervous system effects, which when the sympathetic is activated, increases it. And so by diminishing the SNS or the sympathetic response, we'll be doing the exact opposite of what the sympathetic does, which is to drop the blood pressure. Direct vasodilators really work straight against the smooth muscle, and they reduce the resistance, not the fluid, but resistance. Calcium channel blockers increase sodium excretion and cause vasodilation by preventing movement into the cell of calcium. So by blocking that calcium, and again, dark chocolate, magnesium are both nature's best friend, best calcium channel blocker that you can get out there. And we'll talk a little bit more about detail at the end about what foods can each of these categories has. And then the ACE inhibitors prevent the conversion of that enzyme from 1 to 2. They reduce the angiotensin and then ultimately leads to the vasodilation and the excretion of sodium, or not retaining it, and therefore the excretion of the water. And then the ARBs basically similarly work on the angiotensin II. They prevent that from binding to the receptor walls and ultimately leads to low blood pressure. So you get a good picture with this chart. This is another sort of in a nutshell type slide that you want to focus on. This goes hand in hand with what we were previously talking about. There are some potential interactions that we want to know. Notice that the ACE inhibitor on the top, what's the potential action or interaction we got to watch out? Elevated potassium. This is the second time I'm telling you that ACE inhibitors can lead to elevated potassium, so you got to watch out with that. The ARBs, you want to also can lead to elevated potassium. You want to watch out with grapefruit. Grapefruit it binds to a lot of medication, to a lot of the P450 cytochromes and whatnot. So just be careful because it can reduce the effectivity of that blood pressure medication. You don't want that to happen. Likewise with the calcium channel blocker. Actually, with the calcium channel blocker, what it does is increases the availability, and so that could drop their blood pressure even more. So you do have to watch out with that. And let's see. Prolonged use of diuretics, again, remember zinc, magnesium, thiamine. Again, most of the antihypertensives are going to have a drug-induced nutrient depletion, and I have a chart or a slide later on that'll go over that, show you which ones. And then beta blockers, again, watch out with potassium concentration in the blood. These are, don't worry about this right now, but the A-alpha blockers, the beta blockers, and the potassium sparing diuretics, right, because they spare potassium, can lead to higher blood pressure. And a lot of people think that if I'm on a diuretic, I have to be on I have to take potassium. Not true. If you're on a potassium wasting a diuretic, yes. If you're on a potassium sparing, you wouldn't need to do that. Very important to understand about hypertension. This is, again, sort of going back to the foundational aspect of what hypertension means, and this is why it's a manifestation. A lot of times, patients will have absolutely no symptoms, unless they had a hypertensive crisis, and then they're going to be nauseated, have a heartache or a headache, sorry, and that's an emergency. We need to treat that with some central acting pretty quickly, get that down soon. But most people that we see out there that have high blood pressure, they're going to have absolutely no symptoms until the target organ damage has occurred. So keep that in mind. You might see that somewhere else. I'm giving you forewarnings here. And so we want to try to encourage patients to obviously lifestyle and monitor their blood pressure. And then once they become stable, then they can do their blood pressure or see their primary doctor every 3 to every 6 months. But at the beginning, it's a daily monitoring of that blood pressure if they've been newly diagnosed. This is what I was talking about earlier, the non-selective beta blocker. So let's say you have somebody who comes in with a labetalol, and they're getting an initial dose of it, and obviously they have hypertension. That's the reason they're getting the labetalol. And we know that labetalol is a non-selective beta blocker in that it decreases the sympathetic nervous system activity. By how does it drop the sympathetic? And we know sympathetic is fight or flight, epi nor epi. So how do we block the fight or flight? How do we block the epi nor epi? Well, it blocks both. That's why it's a non-selective, both the alpha and the beta adrenergic receptors. both alpha and beta. It's not a beta blocker. It's not a pure beta blocker. It falls under the beta blocker, but the difference with this one, for example, labetalol, carvedilol, right, propanolol, is that it is not only a beta blocker, but it also is blocking the alpha. So when it blocks alpha and the beta, we call it a non-selective. And with non-selective beta blockers that block alpha and beta, it leads to vasodilation and a decrease in heart rate. And with that heart rate decreasing, what do we have to watch out for? Patients in bed, patients trying to get out of bed, what happens? They get dizzy, right? Their heart rate, their body, if they can, their body can move faster than their heart is able to pump blood to perfuse the brain. So if you move too quick, then and you have a low heart rate, then you should be thinking low perfusion. They're going to get up and out of bed too quick. They're going to end up having a fall. So we need to let the patients on non-selective beta blockers like labetalol, for example, always tell them to, hey, first of all, if you need to get out of bed, you're on a non-selective beta blocker, so please call us when you need. Let us come in, and if you do want to get up, we're going to have you sit you're going to go from a lying position to a sitting position. You're going to sit for a good 2 to 5 minutes maybe, and then we'll slowly get you up, because we want to allow the heart to beat enough blood to perfuse the brain so that when you get up, you won't be dizzy and you won't have what we call that orthostatic hypotension. So watch out for falls with this one, people. Let's say you put a patient on an ACE inhibitor, or they have a new diagnosis of captopril, right? Remember the prils, the ACE inhibitors end up in pril. Again, with these, you want the same exact thing that we were just talking about earlier, right? Also can cause orthostatic hypotension. So what do we need to worry about? And really, this goes across the board with almost all antihypertensives, but specifically with the non-selective beta blocker like carvedilol, propanolol, and labetalol, but also ACE inhibitors. So we want to instruct patients to change positions really slowly to allow the vascular system to have that time to compensate for the position change. Try to make sure you do the blood pressure in the non-dominant arm for newly diagnosed patients. So that's something we would be telling them in the morning. And before taking the drug, obviously, because you want to make sure if they're really, really low, they may not want to necessarily give it. And then in the evening as well, until it can get to be controlled, and then they can reduce the amount of times that they're going to be monitoring it. Again, this is the third time I'm going to talk about ACE inhibitors and how they can cause potassium retention. So with potassium retention, well, obviously, we want to watch out with increasing the intake of potassium foods. That would be absolutely inappropriate to do with an ACE inhibitor. Again, we're back to that non-selective, right? So consult with the healthcare provider before you give this drug, because the patient reveals history of lung problems. So let's say they have reactive airway disease of any type, COPD, asthma. Why? Why does this non-selective propanolol, carvedilol, why does this medication, why do we need to say no to these non-selective beta blockers? Because do you remember? We just talked about it. They block alpha and beta, right? Their non-selective beta blockers block the beta 1s and the 2s, the alphas as well. And what you really need to understand with these propanolol, carvedilol, labetalol, is they can cause bronchospasm and, in other words, bronchoconstriction. Bronchoconstriction. And what do we know already with people who have history of asthma, COPD? It's a disease or a disorder of bronchoconstriction that's already happening. So if you give somebody a non-selective beta blocker, then it's going to lead to the bronchoconstriction. So don't do that. And beta blockers are recommended. They have some evidence has shown that they're protective after a heart attack. And then again, remember, for any reactive airway problem, asthma, COPD, these are a no-no. We're not going to be giving it. Nicardipine is a medication that is often used in a drip form. It's used with IV. And because it's used in an IV form, we want to frequently monitor the patient's blood pressure. Probably they'll be on a step-down unit, maybe an ICU. They're definitely going to want to be on a frequent automatic blood pressure machine monitoring set up. You can get an LV and LPN to help you set that up, but monitoring and assessing the patient is your job as an RN. And so when they're receiving a rapid acting IV for this, you want to make sure that you do have that automated blood pressure machine set up. You have to let the patient know that the machine will probably disturb their sleep, right? So sleep is important, but getting their blood pressure medication when they're on a drip of this nature is more important because of the dangers and the risks that these medications can cause, such as affecting their heart rate, affecting their blood pressure especially. And so we want to try to be careful. Generally, they're going to be in a bed rest. We're not going to want them to get out of bed too frequently or too often, unless absolutely necessary or called for one reason or another. And then we want to be careful with decreased cerebral perfusion or fainting, which is very similar to a lot of the other antihypertensives for the same reasons we've been talking about earlier. So here we are with ramipril, right? ACE inhibitor. I'm just giving you different names so you get an idea, but you got to understand the categories as well, right? This is under the category of ACE inhibitor, and you would want to educate your patient or teach your patient on a couple of things, which means as nurses you need to understand. So they may not work well with aspirin. And does anybody know why? Well, if we know that the ACE inhibitors release prostaglandins that vasodilate, right? They vasodilate, and aspirin, through the same mechanism that these ACE inhibitors and the prostaglandin release vasodilate, aspirin blocks them. It blocks these prostaglandins. It blocks the ability to vasodilate. And so if they're taking an aspirin together with an ACE inhibitor, it may be counterproductive and not effective together. So don't take an aspirin together with a ramipril or an ACE inhibitor. Again, it's an ACE inhibitor, so what do we have to monitor? The potassium, people, right? We also have to monitor that frequent that cough, because it's a side effect that happens with ACE inhibitor. It's not a risk or danger. All you have to do, the doctor will do, is substitute it. Just we can notify the doctor, and they'll probably get him on some other antihypertensive. Again, we should teach the patient, if they notice any angioedema or in the face, swelling of the face, this is life-threatening. It's not like the cough, which we can just sort of just notify the doctor. It could put the patient at risk for not being able to breathe, and we don't want to do that. So let's say you have a patient, again, on an ACE inhibitor, and a patient is having severe headache, nausea, and a very high blood pressure. So what are you thinking? What you should be thinking is hypertensive crisis, right? And hypertensive crisis is a very risky thing. So generally speaking, if a patient's coming into the ED or to the floor and they're having this whopping headache, and together with the nausea and a really high blood pressure, one question that we always want to ask or assess your patient for is, have you been taking your medications? And it's important to ask them that question, because a lot of times if they take medications and just for whatever reason they just suddenly stop taking them, it could lead to a rebound hypertension, which leads to a hypertensive crisis. And antihypertensives, for the most part, like this ACE inhibitor, if it's going to be quit, should be tapered off slowly, and it should be done with the help of the primary care provider or the hospitalist or the intensivist, depending on where you work in the hospital. So always try to assess for that rebound hypertension, because hypertensive crisis is a big risk, and it happens oftentimes because people just assume that it's okay to stop taking their blood pressure medication suddenly. So an allopril or Vasotec, for example, right? Well, because of well, for one, they have high blood pressure, so we want to give them, make sure that they get a dietitian follow-up to talk about diet and lifestyle. We want to talk to them about the potassium as well and the risks for that and what type of foods contain high potassium because it can put them at risk. And then at least check their blood pressure. Try to move slowly again. I'm just repeating myself here. And then that last same one, remember, it can retain potassium, so you got to watch out. And it's an adverse effect that we want to prevent. Loop diuretics like Lasix, for example, what do we need to talk about? The exact opposite of hyperkalemia. It drops their potassium, and so we want to. And remember, potassium. What are we concerned about? Whether it goes high or low? Usually, electrocardiogram, heart muscle, and the conductivity of the heart is going to be affected with either hyper or hypokalemia. So whether you're giving a ACE inhibitor, which could lead them to have hyperkalemia, or you're giving them a loop diuretic, which could lead them to hypokalemia. Generally speaking, if they're here for myocardial infarction and such nature, or have history, they may want to be on a cardiac monitor because low potassium can lead them into having dysrhythmias that we don't want to see. And so before we give a loop diuretic, what are we going to want to do? Obviously, we're going to want to check the potassium, okay? Don't give a loop diuretic without checking that potassium first. So again, let's say a patient is on hydrochlorothiazide, which is diuretic, and an ACE inhibitor, and they still tell you, right, that their blood pressure continues to be elevated. Well, for one, for it to be resistant hypertension, they need to be on 3 medications, not 2. So we couldn't jump to that conclusion yet. But one thing you want to ask about is, are you taking any NSAIDs like Motrin or ibuprofen? Because we know that that can lead to they may be on let's say Motrin for osteoarthritis, and they don't work well together, which could lead to them being on these 2 medications and their blood pressure is still not going down, it's still staying up. So one thing to let them know is, hey, stop taking the ibuprofen, stay on that, take another day or 2. If it keeps going up, then contact your primary care provider, obviously. But don't take these with NSAIDs. Mean arterial pressure. All right. So what is a mean arterial blood pressure? Mean arterial pressure. We look at it because it's a number that helps us know how perfusion is happening. Is perfusion happening as we would like it to happen? And what is perfusion all about? It's about getting blood, which contains oxygen and nutrients, to every part of the body. When people get amputations, it's because they have bad perfusion. When people have bad perfusion to the brain, they're not going to be thinking clearly. Their neurological system, in our assessments, they're going to be altered, right? It could be because of perfusion. And we have a tool at our disposal in the hospital to measure and see if perfusion is happening properly. And that's what MAP, or mean arterial pressure, really is. It measures the flow, the resistance, and the pressure in your arteries during one heartbeat, okay? And so you want to know basically what the what the normal is for that. Does anybody know what a normal MAP is? 60 to 100, okay? And let's see here. So know how to calculate it. So if you have a patient who has a blood pressure of 176 over 82, right, what's the MAP? 113. So you take the systolic blood pressure and you add that to 2 diastolics, and then that top number you divide it by 3, and it'll give you a number. And you want that number to be within 60 to 100. What if it's below 60? What if it's above 100? Well, look at this patient right here. He's got a blood pressure, or she's got a blood pressure of 176 over 82. We calculate their MAP, and we're like, oh, wow, okay, their MAP is 113. That's slightly above 100. So what is that indicative of? Well, as we know, blood pressure is pressure against the artery walls, loss of elasticity. And so any number above 100 is really going to be indicative of an increased pressure in the arteries. And so when you see a MAP that's above 100, not only should we be thinking about more pressure happening, right? But it's putting them at risk for more blood clots and more damage to the heart muscle. So time is of essence. We want to try to bring that back down as best as possible. Not only the blood pressure, obviously, but together with that blood pressure, we should hope that that MAP gets back in to be between 60 to 100. So let's say the patient, you do the calculation, and their MAP is 48, or a MAP of 52, or a MAP of 59, below 60. So if you know what MAP is for, what MAP is measuring, and we know that it's measuring perfusion, then anything below 60 means what? Decreased perfusion, right? Decreased perfusion. So risk for not enough blood getting to the brain, not enough blood getting to the incision in the toe, not enough blood getting to the rest of the body. And so what type of, just like, for example, if your MAP is above 100, what conditions are we really looking at? Well, think of MI, renal failure, heart failure with MAPs above 100. Heart attack, MI, which means myocardial infarction, renal failure, heart failure. What are we thinking with MAPs that are below 60? Any thoughts? Sepsis, bleed. If you're bleeding a lot, and let's say you're having an internal bleed, you're not seeing any blood pouring out onto the bed or to the floor, which would be obvious, and we can try to control for that bleed. But let's say they're bleeding internally and we don't see, and they're not only is their blood pressure dropping, but their MAP is dropping. So their perfusion is going, as that blood pressure, as that internal bleed occurs, wherever it may be, it's their MAP and probably their blood pressure is going to start to decrease as well. So we should always think about internal bleed. And then a stroke. So 3 things to think about with a MAP above 100: MI, renal failure, heart failure. 3 things to think about with a MAP below 60: sepsis, stroke, and internal bleed. So keep those in mind, because that's important. With the angiotensin II receptor blockers, as we call them, the ARBs, some of the adverse effects that you need to understand are these here. Can give you a UTI, can give you diarrhea, can give you weakness, hyperkalemia with the cough, angioedema. These are big things. Angioedema is not an adverse effect. It's an effect we don't want to see. It's an emergency. But a common adverse effect that is seen with ARBs is chest pain. And we can tell the patient that is a common side effect. I want to throw in this one medication specifically. I don't want to go into the whole receptors and what's happening with the alpha-2 agonists. But when you think of centrally acting antihypertensives, clonidine is a key one, and it's usually not given as a front line. It's usually given at the end. So you'll see a lot of times it's given for patients that already are on multiple antihypertensives and nothing seems to be working. And it's one of the last resort drugs that you'll see given. There's patches and other forms as well, but it will lower your blood pressure, it will vasodilate, so it will drop your heart rate. But you got to watch out with this central acting, because it'll lead to drowsiness and dry mouth. That's the side effect of it. And so what we want to tell the patient is, well, suck on candy and increase fluids if there's no contraindication, like heart failure with fluid overload. Calcium channel blockers, again, how do they work? Remember, there's only 2 mechanisms, so this is a repetition, but smooth muscle relaxation, they block the calcium from going into the cell. And what's the ultimate result of eating chocolate or putting a magnesium transdermal spray onto your skin? Chronically, if you use the magnesium, it'll help decrease peripheral smooth muscle tone. It'll help decrease the vascular resistance, and it'll help to decrease the blood pressure as well. So make sure you eat that dark chocolate. Make sure you get that magnesium, because if you don't, you'll probably end up being put on a calcium channel blocker medication. Diuretics, as I mentioned earlier, is when it comes to drug and pharmacological approach to treating antihypertension, it is the first line drug or first line antihypertensive to be used. It is not the first line treatment to be used. First line treatment or therapy or interventions are always going to be lifestyle, exercise, diet, food. And when I say lifestyle interventions, print out that chart that talks about how, the best natural beta blocker is hawthorn berry. Try to consume that in various forms because it'll be helping you and hopefully even prevent you from needing a first-line antihypertensive. That said, diuretics, and the most common one is the thiazide diuretics. And remember, they decrease plasma and extracellular fluid volumes. Remember, there's only two ways, generally speaking, to work on decreasing the cardiac output or decreasing the systemic vascular resistance. One of them is to decrease fluid. So diuretics will decrease that extracellular fluid volume. How will that affect the body? What are the results? Decreases preload, decreases cardiac output, and it decreases as well peripheral resistance. So it's a pretty good medication to give to your patients, and a lot of them will be on it. Sometimes you'll give diuretics to patients who don't have high blood pressure, and a thought that comes to my mind is somebody who's getting 2-3 units of packed red blood cells, for example. Sometimes in between we'll be giving them a diuretic because we want them to get the benefits of maybe the packed red blood cells, but not have a fluid overload, especially if they're already having fluid overload, heart failure. We'll give them a diuretic to get the benefits of packed red blood cells, and in between each dose, the doctors might order a diuretic, and you'll end up giving that to help get rid of that fluid. They may not be getting it for blood pressure, but it'll help their blood pressure if they have it high. But do monitor any patient getting a diuretic, especially if it's IV, for their blood pressure before you give it. The overall effect is it helps decrease the workload of the heart and decreases the blood pressure. And it's really important that decreased workload of the heart is extremely important, because in your mind you should already have that picture of the heart has to beat, it has to work hard to perfuse the body. And two compensatory mechanisms that can happen, as we've talked about quite a few times, is palpitations or cardiomegaly. And if that happens over a long period of time, we're talking about hypertrophic ventricular reaction. So the muscle is going to have to get bigger, and you may assess that apex when you go to listen to the heart with the bell of the stethoscope in the intercostal space number 6, as opposed to the 4th or the 5th, which is where you should be hearing that point of maximal intensity. So you may see with giving medications, although it may need weeks or months before the point of maximal intensity goes back to the 5th intercostal space when you're listening, doing that. But it will have an immediate effect on the decreased workload of the heart. So ultimately, whether the heart is having to work harder by going into tachycardia or palpitations of one type or another, or whether the heart is increasing in size, which is cardiomegaly, we want to have heart rest. We want to rest the heart. So when you see those words, decreased workload of the heart, you should think resting the heart, giving the heart some time. So when you're at home and you're having chest pain and you take the nitroglycerin 3 times every 5 minutes, if that doesn't work, call 911, come on in and get checked. What those 3 nitroglycerins under your tongue are doing is they're gaining time. They're helping you rest the heart, decrease the workload of the heart, same thing, in order to get to the hospital to get checked up to prevent having a STEMI or a more significant complication, which you don't want to have. Now, mind you, one thing I haven't talked about with nitroglycerin, which I should have done, what is the number one side effect of nitroglycerin that we should be talking to our patients about? Well, you want to understand that nitroglycerin is going to vasodilate, and almost all vasodilators, especially the central dilating agents, they're going to give the patient probably a whopping headache, and that's to be expected. So if you're putting nitroglycerin on them, or you're giving them a nitroglycerin sublingual tab, make sure that you let them know that a headache is expected, and that what we're really trying to do is rest the heart. And it just so happens that together with vasodilation, headaches are going to happen. So that's just a repeat. Again, vasodilators, like nitroglycerin, right? Dizziness, headache, they lead to quite a few other side effects. Deficiency of B6 is one of them, but I have a chart later on that we'll look at that. So two vasodilators that you should know about in their adverse effects are hydralazine and minoxidil. One good thing with hydralazine is, as opposed to the beta blockers, is that it won't affect your heart rate as much. And so if you're having a patient that needs to get their blood pressure dropped significantly, but their heart rate already happens to be low, their pulse or heart rate happens to be below 60, we may not want to give a beta blocker. You may want to go into a vasodilator such as hydralazine. But watch out with hydralazine because, again, it's a vasodilator, so it can put them at risk for falls. They can get dizzy, headache. They may have tachycardia with hydralazine, but again, with patients that may be having low heart rate, this is a great medication to give because it will give them tachycardia. On the contrary, if they're already having, let's say, atrial fibrillation with rapid ventricular response and their heart rate's going, 133, would you want to give a hydralazine? No. So there's a lot of factors to keep in mind with vasodilators. They're going to drop and open up your vessels, meaning headache, meaning risk for falls, meaning dizziness, right? Beta blockers, watch out with bradycardia. Hydralazine, tachycardia. Shall I repeat that? Beta blockers like metoprolol, right? Watch out with bradycardia. Hydralazine, tachycardia, okay? And then with minoxidil, there are complications such as tamponade, angina that can lead to some adverse effects. So we want to make sure that they're on a monitor, and we're monitoring them pretty carefully. Sodium nitroprusside is given usually in ICU. Some step downs may give it, whether they titrate or not, depends on the unit and their protocols. But it's a really potent vasodilator, and you want to make sure these are the type of patients you're going to want to slap on or get the LPN, LVN to go in and put on, or CNA, get them on a continuous blood pressure mechanism because of the risks of bradycardia and so on and so forth. A big one with here, even though it's rare, for some reason NCLEX likes to ask about it, is cyanide toxicity. So if you hear and see sodium nitroprusside, always think about what vasodilators do, such as bradycardia, low blood pressure, right? But it can decrease the platelet aggregation, which can lead to risks for some bleeding. Obviously, hypotension, that's any antihypertensive, hypothyroidism, and cyanide toxicity as well. So which statement do you think is true about the ARBs, the angiotensin II blockers? Hyperkalemia is more likely to occur than with ACE inhibitor? Well, we know probably not. We know ACE inhibitors are the number one, not more likely to occur. That'll happen more with ACE inhibitors, so that's a fake one. Cough is more likely to occur than when using an ACE inhibitor. We know that the cough goes with which med? ACE inhibitor. Chest pain is a more common adverse effect. Yes, that's a common adverse effect with ARBs. So that's probably the answer. An overdose is usually manifested by hypertension and bradycardia. No, it would be hypotension. So I threw this in here. Again, I'm very adamant about my drug-induced nutrient depletions. I think there's a place for medications in acute care settings and critical care settings, even as for an outpatient. But for chronic diseases such as hypertension, really we want to try to use lifestyle approach to treat it, because we know that most antihypertensives, Norvasc, lisinopril, furosemide, digoxin, clonidine, propanolol, you see it, right? They're going to deplete your CoQ10, your phosphorus, your potassium, your sodium, your zinc, your calcium, your magnesium, B6, B1. And so forget about the suggestions, but eat healthy whole foods, and you should be all right. These I literally copied and pasted from the PowerPoint presentation that I created for the not the Pharm lecture, but the other one. So they're repeats. DASH diet is one of the best ways to approach it. That's fruits, vegetables in their whole form. I disagree with the fat-free or low-fat, but NCLEX really is still adamant about that. Remember, I think that the fats that are bad are the adipose tissue, that there are really good fats out there. So when we say fat-free or low-fat, if we're referring to raw milk or avocado, it's a fallacy. We want to consume good fats, unless contraindicated for any reason. But anyways, the whole grains, fish, poultry, beans, seeds, nuts, generally speaking, a plant-based diet with minimum fish, minimum meat, especially red meat. And if you're consuming meats like chicken, make sure they don't have any type of hormones or antibiotics, because that'll cause a whole bunch of other complications on its own. Try to eat not necessarily a low sodium diet, but don't add more salt than necessary. A lot of the foods that we eat already have salt in them. But with elderly, we got to watch out, especially if they're dehydrating and hot temperatures, that we were not putting them at risk for death, because they're going to end up having hyponatremia. So watch out. Alcohol in many countries like Europe with the Mediterranean diet, DASH diet, France, Spain, Italy, Greece, 1 or 2 glasses of red wine seem to be protective of that, because they've been doing it for a while. Doesn't mean that those who start newly necessarily will get the benefits from it, but basically moderation of alcohol is extremely important. So if your patient is drinking a 6-pack every day, or if they're drinking high fructose corn syrup, if they're drinking that soda pop every day, or in the movie theaters they're getting that large soda pop, that's going to put them at risk. So that's a huge lifestyle modification that they could take as well. Activity. They need to get that cardiac heart rate up above a good amount, 120, 130, 150, depending on who you ask, for a significant amount of time to get that exercise worked in. But also, getting out in nature is good, which is much more of a moderate as opposed to vigorous, because remember, when you exercise, the risk of having hypertension goes down significantly, which ultimately means risk for hypertension, for cardiac problems, heart failure, myocardial infarction are going to go down tremendously. So physical activity is extremely important. Avoid tobacco. Tobacco causes vasoconstriction. Smoking causes vasoconstriction. All of the medications we're giving, or most, to treat antihypertension is the exact opposite of vasoconstriction. We're trying to vasodilate the body. So if they're smoking, stopping that one thing would be better than even giving a medication. So say, look, if you have to choose between, hey, the doctor eventually is going to give you a blood pressure medication versus stop smoking, well, stop smoking first. You may not need to go onto that blood pressure medication. But that obviously is always the first step to take. So always help and offer help to your patients. And when we say offer help to quit smoking, there are in every county, Alameda, Solano County, Contra Costa County, there are numbers that are easily available. We can just Google the 1-800 number for Solano County Quit Tobacco and give that number, have them call there. In the hospital, we can give some nicotine patches, although if they're here for certain conditions, they may not, the doctor may not want to put them on a nicotine because they're vasoconstrict. So that's up to the doctor to order, but we could consider that if they're in the hospital and not getting nicotine, we don't want them to withdraw too fast, too soon as well. Eliminate sodium completely for good health is wrong. We don't want to eliminate it completely because it is an essential nutrient. And it helps with controlling the blood pressure. It is needed for the nerves. It's needed for the muscle to work properly. We just need the right amount. So be careful with adding more of it. And when we say sodium, it's table salt that is the big risk. It's sodium chloride that is the big risk. Most of the salt that you're going to want to get, like Jonathan Wright has his version of it, there's whole forms of flaked salt. Sea salt, some people claim risks for mercury, although sea salt is in a whole form better than the table sodium chloride. Bottom line with that is you want to get a salt that is in a mineral form, a pink Himalayan salt is in a mineral form. So you want to get the sodium in a mineral version, in a mineral form, as opposed to simply table salt. So if you're putting table salt when you go to the restaurant, that is going to definitely put you at risk for high blood pressure and a lot of other problems. So don't use table salt. Don't add table salt. If you do use salt for cooking, try to minimize the use of it and try to use a mineral salt as opposed to a table salt. And I'm going to let you go over this. Nitric oxide is really powerful. Arginine helps build it in the body. So do a lot of other foods as well. So vitamin D is important. So we want to get that sunlight in there. So those are the two big things with this chart right here is eat foods that have that arginine in it, L-arginine, and also with the vitamin D. If you aren't getting enough through your consumption of it orally with K2 as well, make sure your D3 has that K2. It's important. Make sure you get your sunlight. Just if you tend to be white and get like risk for solar cancer on the face, don't expose your face, just maybe your chest and your legs, and get that vitamin D the natural way. So here's the interesting part that we already talked about. This is just a quick repeat. So remember, I already gave you a chart previously that you should be looking at. What do diuretics do? You should be able to say they promote they don't hold on to the sodium. They promote sodium excretion. And what happens when sodium is excreted? Water is going to follow it. So what do they reduce? Two things: plasma and extracellular fluid, right? Remember, in response to those catecholamines, that's how the diuretics, for example, are responding. Calcium channel blockers, how do those respond? Well, they increase the same thing, sodium excretion, by causing the arteries to vasodilate, right? And so it prevents basically the movement of what? Calcium into the cells. This is like the third or fourth time I've said that. By preventing the movement of calcium into the cells, they're helping with all of that vasodilation, and they're helping as well ultimately with the excretion of that sodium. Beta blockers. How do beta blockers work? Well, we've already talked about that. There's two types. There's the general beta blocker, and then there's the non-selective beta blocker. The non-selective work on the B1s and the B2s, and they do what? We got to watch out with what with those? Bronchoconstriction, right? So what about ACE inhibitors? You guys should go back to that chart and remember what ACE inhibitors do. They prevent that angiotensin II from what? Binding to the receptors and ultimately lead to what? Vasodilation as well. So that's an important thing to those were the ARBs, sorry. Those were the ARBs. I'm confusing them there. The ACE inhibitors prevent the angiotensin I to the II conversion as well. So they work on vasoconstriction, preventing it, meaning help with dilation, and also sodium and water. And then we talked very briefly about the hydralazine and the minoxidil. So go over and try to get an idea in your mind. Be able to do what I did was just sort of it requires a little of thinking, but you should get to that point. And remember, when you look at these categories, right, of drugs, remember that there's ultimately only two ways of affecting the blood pressure: cardiac output and systemic vascular resistance. And those work by getting rid of the fluid or by decreasing the resistance that the heart is working up against. These are my favorite slides. I'm not going to go over this. I'm not going to read it, look at it, but you just need to know that science is already indicating that there are foods out there that act literally as a calcium channel blocker. The omega-3s, especially the eicosapentaenoic and acids and the docosahexaenoic acid, the EPA and DHA, I hate those words. When you buy omega-3 fatty acids, fish oils, or things of that nature, you can get them vegan as well. Make sure that they're high in EPA and DHA. Now, EPA and DHA or omega-3, you have to watch out because just like ginger, garlic, ginkgo biloba, aspirin, they may put you at risk for bleeding. So if you're taking a heparin or other Coumadin or medications of that source, you want to watch out that they're not thinning your blood too much. But they work as calcium channel blockers, like vitamin C, B6, vitamin E, but the gammas and the deltas specifically. Hawthorn is a wonderful thing for the heart. like taurine, garlic, alpha lipoic acid. Significant amount of research coming out on how garlic can affect the heart beneficially. And beta blockers, as you can see all the way at the bottom, the key natural beta blocker is hawthorn berry, people. Now, there's a lot of different ways. There's a university out there, non-accredited university and all of that stuff, but what they do provide a good amount of information. Hawthorne University, they have a YouTube website, and they have really good talks in terms of things to do, not only for hypertension, but for a lot of other conditions. And I appreciate a lot of the information that they put out. So if you want to get some upstream sort of chronic care lifestyle approach, Hawthorne University is a good place to go to. And they call themselves Hawthorne University for a reason, because Hawthorne is a really very strong, wonderful medication to take for the heart, for blood pressure. And in Chinese medicine, it's used tremendously. And then the hawthorn berry itself, if you can get a hold of it, has a really sort of acidic, bitter flavor, but they coat it in China with some brown sugar, and it's quite good. You can buy it on the street, and it's good. Diuretics, all of these are diuretics. I'll let you look at that. Calcium is a diuretic. CoQ10 enzyme, hawthorn berry, again, people. Magnesium is again another. Not only is it a nature's calcium channel blocker, like dark chocolate, make sure it's above 70%, 72% or above. So make sure you eat chocolate that's not like the Snicker bars. That's not the chocolate we're referring to here. We're referring to dark chocolate that has the purpose and serves the role of as a calcium channel blocker. Celery is really good. A lot of people, when you do your juicing, put in some celery and some apple, and celery will help and work with diuretics. Now remember, if you're already having low blood pressure, you're already peeing a lot, or you're already on a diuretic, consuming a lot of these things will just put you more at risk for urinating more, for dropping your blood pressure more. So you just have to, be careful with that, and be careful if they're taking these things together with the blood pressure medication. What about angiotensin converting enzyme inhibitors, or ACE inhibitors? Garlic, seaweed, omega-3s, gelatin, sake, dried salted fish, fish sauce, zinc, melatonin, pomegranate. Pomegranate is another, the granadas are another really good fruit that is tremendously heart protective as well. Used in a lot of herbalists' repertoire is pomegranate. So eat that when you can. What about the central alpha agonists? Remember, central alpha agonists reduce the sympathetic nervous system. Sympathetic nervous system. They reduce what? Epi-norepi. And so by reducing that epi-norepi reaction, by reducing that fight or flight, so central alpha agonists, remember, central alpha agonists are reducing that fight or flight. What can we take for that? Potassium, sodium, zinc, protein, vitamin C, fiber, B6, CoQ10 enzymes, celery as well, garlic, taurine. You see a lot of these have very similar effects on the body. And so that's a repeat of the central alpha. I just happened to put it on. So here's the ARBs. What do the losartans do? Or the angiotensin receptor blockers, the two blockers? Same thing. Resveratrol, fiber, which is in the grapes, good for the eyes, fiber, garlic, vitamin C, B6, CoQ10, celery. So if you get a good image, there's quite a few things that you can start taking that are going to have these effects on you. Direct vasodilators, omega-3, omega-9s, potassium, magnesium, calcium, soy, fiber, garlic, C's, E's, CoQ10s, L-arginine. Remember, L-arginine does what? It helps. It's a precursor to the nitric oxide. L-arginine, a lot of people who have erectile dysfunction, it's really funny, right? Because people will be on an antihypertensive, well, funny, by funny I mean sad. They're on an antihypertensive, which has as a side effect erectile dysfunction, and then they go out to the market and they're never told, unfortunately, in many circumstances, that, hey, lifestyle can clearly help your blood pressure. So they're already on an antihypertensive, which leads them to having erectile dysfunction. So now they go and they do all their literature and their research, and they really get into understanding what can they take that'll help their erectile dysfunction problem so that they can get that erection. And then they find out, oh, L-arginine is good for that. Well, people, if we start with diet and lifestyle at the beginning, they may not need to be on that antihypertensive, which is giving them that side effect in the first place. So I'm all favor about whole foods, plant-based, mostly plant-based. Remember I'm broken between that sort of Dr. McGregor plant-based diet, and I'm with him 100%. But then there's the opposite field, which is Western Price Foundation, and they argue that it's okay to eat meat, liver, and raw milk and butter. But again, when the Western Price Foundation talks about that approach of diet, they're really talking about local farms that you can go to, farms that you can visit. You know what type of animal and meat and butter you're getting. You know what type of milk you're getting. You're going directly to the farm, or you're buying it from a local whole food store like Nugget, or that they're purchasing it from someone who's local, and you're supporting that business as well. So you see the point that when it comes to diet and whole foods, plant-based for the most part, and in some people, maybe eating minimally some meat can play an effective role. Liver, for example, if it's organic, has no hormones, has no antibiotics, comes from a source that you trust, tremendously powerful with vitamin A's, D's, and E's. And so just some liver, for example, can be treated in a way as a form of medicine if you're not getting it from being able to go outside. Remember with A, D's, and E's, though, is that they're fat soluble, and so you don't want to consume too much of it because it can stay in the system a lot longer. This is just a repeat of what we had earlier. This is a repeat of what we've been going over, just examples of what some diuretics are. And these are just, I think this is the last slide, it should be, I hope. Diuretics and potassium drops lead to, so you take a diuretic, it drops your potassium. You need potassium to keep your vessels in proper condition, and it leads ultimately to hypertension. So same thing happens with all the others that have drug-induced nutrient depletion, which could lead to a CoQ10 depletion, and that CoQ10, when it's low, leads you're not able to work against those three mechanisms, which are that chronic inflammatory, that oxidative stress, and that autoimmune. So your blood vessels, the arteries at the endothelial tissue, they don't have that CoQ10, which is an enzyme that's absolutely needed to help with the elasticity of the blood. So what ends up happening? You get on a second drug, and a third drug, and a fourth drug, and maybe even a fifth. By that time, you're probably in ICU, and they're pounding on your chest, and they're loading the patient up with epinephrine, and nothing is working. Nothing is working. Why? Because underlying what's going on in their blood and at the endothelial cell, there's nothing there. There's no nutrients there, people. So when you can do it whole food, by all means, do it. Hydrochlorothiazide will increase homocysteine. We know that homocysteine is a marker for an inflammatory, and it puts you at risk for Alzheimer's, schizophrenia, depression, chronic pain, cancer, hypothyroid, a whole Parkinson's, right? So homocysteine, when it's elevated, is not a good thing. Hydrochlorothiazide increases homocysteine. People, if it's not clear that medications are a risk for your patients, then think again. They are a risk for your patients. Again, magnesium and omega-3s play a major role across the board. Make sure you take your magnesium with calcium, vitamin D, and probably some K2. Again, if your patients are acutely ill or chronic or critically ill, they're on blood thinners, I wouldn't take any of these things. Be careful. Make sure you can stabilize them. Make sure that they're not at risk for bleeding. Make sure they're not at risk for clotting. Once they get back out to their chronic care setting, which is back at home, then we can get back on board and start working with whole foods and whatnot. The C-reactive protein is also a major indicator for inflammation. It's just not good to indicate where you're having an inflammation. It's just good to tell you. So it can't tell you if your heart is having inflammation, or your liver, or your lungs, or your brain. It just says, dude, you have an inflammation or an inflammatory response going. Well, people, isn't that what we've been talking about all along the Watchtower, is that we're having an inflammatory response chronically? So proper diet plays a tremendous role in trying to work to bring down that C-reactive protein. There's a highly sensitive C-reactive protein, which is better than just the C-reactive protein. And let me put it this way. If you go to your doctor, and if you're having to convince your doctor to check your vitamin D, your homocysteine, or your highly specific C-reactive protein, get another doctor. Go to a doctor who's already up to date with this information. That's what I tell my patients. because I think this is information that if you and I as nurses are now coming into this information as frontline, as important for lifestyle modifications, the doctor should be aware about this as well. And it's that's why continuing education exists, to make sure that they're not just going out to a resort to drink their Cabernet with that nice little steak, but that they're actually learning this material, which you and I and any healthcare professional really needs to be aware of all this information, which is why I'm bringing it to the table, because I want you guys to be a better healthcare provider like I am. I've gone through learning all of this material, and so are you by being here present in this talk. So I appreciate that, and I really talk like this and bring this forth because I hope that you can really bring this to that bedside, because most of you probably will end up in acute or critical care, and your patient is going to end up, when they leave that acute care setting, going back home. They need to know this. EPA, DHA, we talked about that. It's part of the omega-3, really important to have. Make sure you're taking vitamin D3 with K2 because it helps with the absorption of the D3, but it literally, there's evidence that shows that it pulls calcifications out of the artery. So people, if science, evidence-based, remember, nurses are evidence-based practicing professionals. And if there is evidence that indicates that D3 and K2 can help with that endothelial level of care that we want to provide by decreasing the plaque and the buildup, and we know this does it, then by all means, we should absolutely be on it. And this is the last slide. Follow this link and read this article. The title of the article is called Hypertension. Is it time to replace drugs with nutrition and nutraceutical? It's long overdue. Now, this wouldn't apply for acute or critical care settings. Absolutely not. If you're having a hypertensive crisis, you don't want broccoli. And you don't want that dark chocolate. You want to get a Centrovase, you want to get nitroprusside, you want to get that slapped on, make sure you bring that blood pressure below 200, below 180 to where it needs to be. Monitor the map, do what you need to do as a critical care or an acute care nurse. All of that is wonderful. But when we're talking about chronic care, upstream, outpatient settings, we know that nutrition, nutraceuticals are the way to go. And so read that article. I would highly, highly suggest you do. Thanks for attending and listening to this lecture. And most of what I'm going to be asking you in the Pharm exam is actually in this PowerPoint. Most of it is right here, right there. I've given it to you. Most of them I've repeated multiple times. So I thought I was generous enough to put them in various times to let you know what it is that I want you to expect, that I expect you to know for the Pharm quiz. So don't stress at it, review this, go over it, and have a good rest of the day or evening.